started. We're almost at 1,000 people joined, but people will still come on and we got lots to talk about. So we're getting started now. So, all right. So let me formally introduce myself and you. So my name is Dr. Corinne Menn. I'm a board certified OB-GYN and a North American Menopause Society certified menopause specialist and a long-term breast cancer survivor and a medical advisor and a prescriber at Alloy. And I'll let Dr. Haver introduce herself.
So my name is Dr. Mary Claire Haver. I am also a board certified obstetrician gynecologist, and I'm also certified in culinary medicine, which is a medical nutrition program through Tulane University. And I'm the creator and founder of the Galveston Diet. I've also chosen to practice here in Texas and focus my care on menopausal women only.
So I think one thing that we both have in common is that, well, we're obviously both OB-GYNs, but we both had some personal experiences that led us to focusing, our practice and really kind of educating ourselves on this transition. For me, it was, I was plummeted into premature menopause multiple times from cancer treatment, diagnosed with breast cancer during my OB-GYN training at the age of 28, realizing that, by the time I went through chemo and had surgeries and had my ovaries removed, I was really suffering, and my own doctors and myself, I did not have the knowledge to care for my menopausal symptoms. So I had to educate myself. And that was really powerful in, changing my practice. So, can you tell us a little bit about how you got to what you're doing?
I was, traditionally trained in OB-GYN. And when I finished my residency and passed my boards and did all that, I would have told you that I was a great menopause provider. Because I learned everything they put in front of me, right? And did everything they required of me in residency. And it wasn't until, I was out, when I first got out of practice, you tend to be kind of as old as your patients are. You start out with younger patients delivering their babies and then transitioning with them through perimenopause and menopause. And I was going through the same journey with my patients and realizing multiple complaints kept coming up time and time again. And I would give the same stock answers of, work out more, eat less. This is just midlife. Welcome to the journey, without really giving concrete solutions for the care. And, I realized there was something wrong that, and I was terrified to give people hormone therapy, that I might give them cancer. That was kind of my understanding at the time. And the American board, who we recertify with every year, was not putting new menopause articles or any of the current research in front of me, requiring me to kind of keep up. It was all important stuff: oncology, pediatrics, gynecology, surgical techniques, but really menopause. Not only was it very little taught in my training, but we weren't, like, the CMEs were just not there, the continuing medical education. So when I started realizing I'm suffering terribly, my patients are suffering, is this the best we can do? And started digging in to the education and the research, I realized, wait a minute, we're getting this wrong. Going to the NAMS website, seeing what their recommendations were, I was like, whoa, this is very different as to what I thought my perfect knowledge was, or, as good as could be. And that there was a big gap in, what started for me and my patients was weight loss was the pain point. And that's how the Galveston Diet developed. But then as I dug in deeper, I was like, whoa, this is way more than just weight loss. This is health risks. This is bones. This is genital urinary. This is mental health. This is cardiovascular. There's so much more to this than I actually realized.
Absolutely. And, we were just talking offline about this, about how, it's a systemic problem, and that we support and understand that busy OB-GYNs and primary care medical doctors, they're really not to blame, because the system is set up in a way that is antagonistic for them to level up their knowledge and provide access to the information. We've all been traumatized by the Women's Health Initiative misinformation, and people have not updated their knowledge. But there's a lot of systemic issues that go on why doctors just literally don't have the time. And that's why it's really important to listen to your gut. If you're not getting what you need from your primary doctor, seek out someone who's doing evidence-based, NAM certified, or at least, menopause literate, care.
Yeah.
So what would you say about women's experiences with their primary doctors and their OB-GYNs?
So, I only knew what was happening behind the closed door that I was in with my patients. And you probably can speak to the same thing. And it really wasn't until my following exploded on social media and I was reading thousands and thousands of comments about what was being said to them by healthcare providers, the misunderstanding, the misinformation, the gaslighting, the dismissal, and I really didn't realize how many women were suffering to that degree. And it really, one of the beauties, I mean, social media, I'm suffering as well as everybody else from an overexposure to social media. But gosh, it has really made me want to become a better provider. That is what drove my education. I'm not doing the bench research. I'm reading other people's beautiful research and evidence that is out there, but just not being shared in a way that is, and God bless the healthcare providers. I was one of them. You get paid to deliver babies in OB-GYN and do procedures. Yes. That is how your employer makes money off of your work. And for you to sit there and untangle and tease out perimenopausal symptoms, menopause symptoms, in the 11 minutes they give us to see a patient and do the exam, there's just not enough time to do it real justice.
Yeah. Yeah. So I always point that out and say, I'm defending our doctors because of that.
Mm-hmm.
So, with that as a jumping point, while we have you as this wonderful expert, let's, at Ally, we're always trying to, dispel myths and, provide access to information. But I think it's really important for women to hear it over and over again from lots of different, really credible sources. So we've got you. So some quick little, fast lightning facts before we get into the whole weight, perimenopause, and menopause. So should women be afraid that hormone therapy causes breast cancer?
No, not at all.
Thank you. Hormone replacement therapy or menopausal hormone therapy, you should use the lowest dose for the shortest amount of time.
No, not at all.
True or false? Do the benefits far outweigh the risks for most women who are within that lovely 10-year window of menopause?
Absolutely true.
Yes. And what about women who are, a bit older, or maybe they had been on hormone therapy for very many, many, many years and they're in their late 60s now and they're doing well and they don't have a contraindication? Do they need to stop?
Absolutely. Keep going.
Okay, good. And hormone levels, do we need to check them, Dr. Mary?
No,
okay.
We don't. Rarely. I don't want to say never. Rarely.
Yeah. Pellets.
Pellets. Pellets are a form of compounded hormone therapy, and they're not controlled by the FDA. And there's a tremendous amount of misinformation, and I think a lot more harm than good is being done. They're being given for people with not nearly enough training. People are literally going to weekend courses and learning how to, do hormone therapy, and it really, they're being overdosed. They're being given super physiologic doses. 100% of the patients are being given testosterone who don't actually probably need it. And I really feel like we have great, efficacious FDA approved options that have been proven to be safe, whereas compounded is not FDA regulated, not tested, not approved, yes, I use compounded formulations, but by far and wide, I'm going to go with an FDA approved option because I know the safety profile has been checked. And I think that people are being lulled into pellets and being convinced that they're somehow better, more efficacious, safer, and that is just not true.
Yep. Thank you for reiterating.
No evidence to support it. Yes, I use compounded options occasionally, but that is not my go-to therapy.
No, and I think what we were saying before is that there's a void in information and there's a void in access to high quality, care, dealing with perimenopause and menopause. And so women are denied access. And so they see, oh, there's a whole cottage industry and these people are going to take care of me and make me feel like they're going to do special lab tests and they're going to have me come in every couple of months to check on me and, charge me a lot of money.
So I think it's expensive, it's untested. And I feel like if you go into your healthcare provider's office and you and your healthcare provider together decide that hormone therapy is a good option for you, you deserve a discussion around every single option available. And if they're driving you to one option or saying, I only use pellets, then you need to get up and leave. Because that is unethical, because they are personally profiting from the sale of the pellets. And if they are not giving you all of your options, if you and your healthcare provider, after an extensive discussion of every option out there available to you, decide that pellets are the best for you, then go for it. But if you are, and you don't mind paying the premium, then go for it. But if you are being driven and not given other options, that is an ethical issue, and I would not do it.
Big red flags. Great points. So let's just get into what's really happening metabolically and hormonally, in perimenopause, because I think, women understand menopause. Okay, I'm not having any, ovarian hormone production. My levels are really low. And we're going to talk more about that. But in perimenopause, I feel like that's when I often have seen women be the most symptomatic. And also that's when they start to come in really concerned about their weight. So, from your point of view of what you've learned, what's happening from that metabolic standpoint?
So, post-menopause is really easy for us to diagnose. No period for 1 year over the age of 45, or, a simple blood test can diagnose it usually in post-menopause. Perimenopause, because the hormone levels overall, if we normalize the curve, so I don't know how people are looking, but, on a graph, we have the X and Y axis, the estrogen levels are going to look like this over time. But what's actually happening on a day-to-day basis is this wild fluctuation with a downward trend for what used to every month look like an EKG. Okay. I mean, it's the best way I can describe it. And so a one-time blood test or a one-time urine test or 24 hours of spitting on something or peeing on a stick is not diagnostic. Okay. It is, a lot of people are getting diagnosed with a non-medical term called estrogen dominance. That is not a recognized ICD-10 code. That is a marketing term, not a medical term. You literally can talk to the patient and be able to diagnose her perimenopause. Estrogen dominance is another term that gets thrown out there. Estrogen dominance.
Saliva testing, right? We don't need saliva testing. We don't need urine testing. We need to listen.
So what's happening is our ovaries are beginning to sputter. Okay. You don't go from normal reproductive function to complete stop. Okay. It's not a hard stop. It is a transition, and the transition can be wild. And it's where we see the dramatic escalation of fat deposits in places you probably never had them before, the dramatic escalation of muscle loss, 30 to 40% decrease in your brain function. Okay. And how your brain is utilizing glucose, a dramatic increase in your mental health issues. So everything from anxiety, depression to ADHD. We're seeing an increase of palpitations. Your cholesterol, with no changes in diet and exercise, 0. You will see an increase in your LDL, a decrease in your HDL, and a possible increase in your triglycerides. We are seeing an increase in your vaginal dryness, in your decrease in your sexual function and your sexual feelings. We're seeing an increase in hip, joint, musculoskeletal, and arthritic pain. There is not an organ system that is spared in this process. We have estrogen receptors everywhere in your body. And we're so biodiverse as individuals that we are all having kind of a different symptoms. So it can be difficult for an untrained physician to be able to recognize that this sequela, this, constellation of symptoms is how your perimenopause is presenting. Now, what started this journey for me and for my patients was, what the hell? They'd sit down for their well woman, grab their bellies and shake their tummies at me.
What's happening down? Like, why do we have this?
What is this? I'm not doing, and 35-year-old me would say, work out more, less. Yeah. Work out more, eat less. Bring me your food journal. Let's count your calories. I knew nothing about nutrition. I joke that nutrition was like porn. You know it when you see it. And so good nutrition, you just know good nutrition. You don't need a class on that. You should know what good nutrition is. I got my socks knocked off when I went back to school to learn about nutrition and the quality of nutrition and how, micronutrients affect our enzymes, our hunger hormones, our satiety hormones, the hormones that drive how and where we store fat. And that's kind of where the framework for the Galveston Diet came out, was me trying to help myself and my patients. And I was just prescribing this eating plan, which is what a diet is in medicine. And then
everything, that you just described is why all the medical specialties, and particularly our primary care doctors and our OB-GYNs, they're frontline. They really need to understand this, because this is really impacting, it's not just hot flashes and vaginal dryness. It's impacting, your overall health and, putting you at risk for chronic diseases if we don't use this as an opportunity to make good quality changes.
So what we're seeing in menopause, of course, with aging, we have the weight gain is increasing and it accelerates beginning at your beginning of perimenopause journey. I don't need a study. There are multiple studies to prove this, but women will tell you this. And so what's happening if we opened you up is we're seeing muscle mass is decreasing, which is decreasing your basal metabolic rate. Your fat mass is increasing and it goes up dramatically in perimenopause. But where that fat is being deposited, and this is where the health issues come, is changing. What used to be subcutaneous, and you may still continue to have that, that's fat under your skin. That is the fat you've known your whole life. That is what gives you curves, cellulite, you can pinch it. It's cosmetically distressing, but in small amounts, it is not that dangerous, okay? When we start getting the intra-abdominal visceral or belly fat deposition, where your tummy looks pregnant, okay? That fat accumulation is inflammatory. It becomes a pro-inflammatory organ and starts increasing our risk for hypertension, diabetes, cardiovascular disease, stroke, cancer, autoimmune disease, 7 of the top 10 leading causes of death in women. Okay. So fortunately, yes, if I locked you in a cage and starved you, I tell my patients this, you would lose visceral fat. You'd also lose your hair, your mind, and your muscle mass. We're not doing that. Okay. There are nutritional things that you can do that will decrease your visceral fat or have been shown in women. And one is watching your fiber intake, making sure you're getting adequate amounts of fiber. 2 is watching the added sugars, not fruits and vegetables. We've demonized sugar by the keto movement, but, naturally, and so people were stopped eating fruits and vegetables by and large. And so that has been really harmful. We're not getting enough fiber. We're losing a massive amount of micronutrients. And yes, while the scale may move in a direction that makes you happier, your health is not moving in a direction that makes you happier. So that's kind of my focus with the Galveston Diet was, cosmetically, I get it. I grew up in the same generation. I was driven by the scale. I know the pain. I feel it. But in an effort to hit that number on the scale, we were losing massive gains in our health. We were losing so much muscle and not setting ourselves up for success for a healthy last 30 years of our lives.
It's interesting what you just said about the decreased amounts of fruit and vegetable intake, even though we all know, society, we should all know that we need more fruits and vegetables. But there is this huge movement with the keto and the low carbs and the, protein heavy, which, but these extreme choices are depriving us from really nourishing these, macronutrients, obviously, and the nourishment. I didn't think about that women are actually eating maybe sometimes less fruits and vegetables because they're being pushed to these bad diets, frankly.
And by limiting the fruits and veggies, they're losing fiber and vitamins, minerals, and micronutrients that are keeping us healthy, that are affecting the hormones that are controlling your hunger and your satiety, your leptin and your ghrelin. We are meant to have complex diets, rich, I call it in the Galveston Diet, we call it eating the rainbow. We have contests to see how many colors you can get in during the week of different fruits and vegetables, because they all have individual nutrient profiles and are just so important for us to hit all the things that we need.
Yeah. And I think it's so important to drive home the whole idea of this visceral fat and this state of more inflammation. Because I know from reading your book, that's really kind of the key that we're really want to target, is this idea of inflammation. And it's so interesting at NAMS, they, talked about how this past fall of how vasomotor symptoms are intricately linked. It's direct correlation with the amount of hot flashes and vasomotor symptoms you have, the amount of inflammation that's happening in the small blood vessels and other.
Exactly. And super flashers,
yeah,
the super flashers, people who are like, it's hard to quantify hot flashes, but basically if you are continuously disrupted by hot flashes, then you also are higher risk for cardiovascular disease.
Every single marker.
It's all related. It's not just hot flashes are annoying. I get them. I had them. They were horrible. But that's also a big red flag. Your body's trying to tell you, you are super high risk for these impending, and so we've got to do everything we can. And when I, in my clinic, I'm fortunate I have a machine that measures muscle mass and visceral fat and all the things. And so, but I call it the menopause tool. And so that you get a prescription for your nutrition, you get a prescription for exercise, you might get hormonal prescriptions more often than not. Yes. Other pharmaceuticals that may be necessary, especially if you're not a candidate for hormone therapy. We talk about stress reduction. We talk about sleep optimization, and all of the things have got to work together to keep us as healthy as possible.
So your main pillars, you want to dive into like the big pillars of the Galveston diet. And I do want to just say, like, I always tell when I recommend your book and I talk about this, I'm like, it's not really a diet, and Dr. Haver will say, like, she called it the Galveston diet because that's where she's from. And this is where the movement started, but it's really not a diet. It's not a restrictive diet. So you want to like comment on that and just talk about the pillars.
So yeah, diet, 4-letter word. I get it. If I could do anything different before I published a book, would be to change the name. Galveston is the place I've chosen to call home, where I raise my kids, where I live today, where I'm talking from right now. But a diet in medicine is a pattern of eating. And so I wanted to describe a pattern of eating for my patients that would promote more health instead of just the rigid calorie counting and them just being obsessed with calories or keto or whatever fad was going on at the time. And so when I dove into the literature on how to lower inflammation and what's going on in menopause with chronic inflammatory levels, I kept seeing patterns of things that were coming up. One was an anti-inflammatory. What is anti-inflammatory nutrition? Like, what are foods that we know naturally fight inflammation, have powerful antioxidants and anti-inflammatory components in the foods naturally? So that's going to be your fruits and vegetables, your legumes, your whole grains, some dairy can be, if you're not allergic to milk proteins or have a lactose intolerance, dairy can do well, especially loaded with probiotics like in yogurt. We talk about things that we know promote inflammation. We cover this all in the book. And so we talk about how things like gluten-free is really demonized and really taken out of proportion, that we're throwing out the baby with the bathwater because we're missing out on whole grains for those of us actually who can tolerate it fine,
Fiber,
which is
right.
Because of the fiber. And so that's one pillar. Second pillar is, if you're a good candidate for it, and most people actually are, is intermittent fasting can be really powerful for women. Of course, you can take anything to the extreme and undo the health benefits of it. So you have to be really careful. So when I coach people through considering fasting, we really start slow, and you over several weeks increase your eating window until you find a rhythm that is comfortable. You never want to feel like you're starving. You never want to feel like you're lightheaded or dizzy, or you can't get your workouts in. So it is a process. It took me about 6 weeks to become fasting adapted. And I can pretty much, life gets in the way, of course, or I'll get invited to a brunch or something late night. It doesn't always work out, but 90% of the time it's my normal habit of using intermittent fasting as a healthy part.
What's your ideal window that you promote?
I coach around a 16-8 typically. So fasting every day for about 16 hours and trying to eat within an 8 to 10 hour window. So 14 to 16 hours, eat within 8 to 10. And then the third is really doing a lot of education. We call it fuel refocusing around macro and micronutrients. We kind of start, if you have a lot of weight to lose, around lower carb, kind of learning. And that's more about adjusting to like getting rid of some of the sugar in your diet, replacing that with naturally occurring, some of the added sugars in cooking and processing, and going more to natural occurring fruits and vegetables, and really doing a lot of education around micronutrients, fiber, magnesium, calcium, phosphorus, zinc. We talk a lot about that in the book. I do a lot of education around hormones, not only estrogen, progesterone, testosterone, but we talk about leptin and ghrelin and insulin and cortisol so that, and I try to do it in a way that makes sense to a layperson who doesn't have a medical background. I learned so much about that in my nutrition studies. So I just try to wrap that all up in a bow. And so those are the three main pillars of the program.
And I know that you talk about, it's so important for us to nourish with whole foods and real foods, but there's a role for some supplements.
Yeah.
We get asked all the time. And I've been a big fan of the things that you recommend for a long time and have taken them, and, happy to see all the evidence and science that you talk about those things, omegas and vitamin D and magnesium. So do you want to just mention a few of those? Because people
Absolutely. You should get most of your nutrition from whole foods. That should be your goal. But we know you have allergies, you have intolerances, there are financial problems, you don't have fresh options available. And it's really hard in the SAD, the standard American diet, to get everything you need. And our culture, our community, our world, the grocery store is not set up for this success at all. Okay. It's set up for convenience. We're running our kids to all these soccer practices and things, and you're running through drive-throughs and grabbing convenience foods. I get it. I had 2 kids, and so women are really struggling to get enough fiber in their diet. So I usually recommend a fiber supplement. Almost all of my patients are deficient in vitamin D. It's approaching 100%. And so I recommend a vitamin D supplementation. You can go up to about 5,000 IUs safely per day. Some can do more, but anything over 5, you really should be monitoring vitamin D levels to make sure you're, getting enough. We're having trouble absorbing. And we're staying out of the sun to protect our skin, understandably. And so I have a vitamin D supplement that has omega-3 fatty acids and a little bit of K added, vitamin K to increase the bioavailability. And so I also have turmeric. I don't recommend it for everyone, but turmeric, if you're not getting into your diet every day, can be really powerful to help with hot flashes. It helps with visceral fat deposition. It's a really nice antioxidant, anti-inflammatory. And then I often recommend magnesium if you're struggling with mental health issues or sleep. Magnesium L-threonate has some great studies associated with that. If you're struggling with constipation, something like mag oxide is a little tough on the gut, but mag citrate can also raise levels if you're, pumpkin seeds, spinach. There are a lot of foods that are rich in magnesium there. And then collagen. So collagen, I started totally for vanity. I was struggling with the appearance of cellulite. As a thinner person, cellulite is no prettier hanging on bone than it is with some muscle behind it. And so I started, there were some great studies looking at wrinkles and cellulite, depth of the dimples, with this particular form of collagen. So I co-branded with a brand that I love that I had recommended for a long time. And so it turns out there's later studies that have come out that shown that collagen supplementation can be really helpful for women with osteoporosis. And so I'm recommending it to help keep bones strong, as well. So those are kind of the big ones that I talk about usually.
Awesome. So, I think you and we both agree, we have to think holistically about everything. And you use the term like a toolkit, your toolbox, and you got different tools in it. And I always tell women, I can put you on a menopausal hormone therapy and it's going to help your hot flashes and your night sweats. You're going to sleep better. But if you're eating like crap and you're not moving your body and you're not maintaining muscle weight and you have terrible stress and you're, it's all part of it. So we talked a lot about, obviously, all the important nutrition. Will you just, from your experience, what have you learned about how, and I always tell women, menopausal hormone therapy, it's not a weight loss drug,
No.
it's a weight loss drug. No, but it's a tool to help you feel better. So do you want to kind of dive into that a little bit?
So hormone replacement therapy can do a lot of things, and it's one of the tools in the toolkit, but you cannot rely on that one solely. You must if you want to be as healthy as possible. So what hormone therapy has been shown in studies, like women who were on hormone replacement therapy versus those who aren't, they all gained weight, more to do with aging, but the women on hormone replacement therapy had lower accumulations of belly or visceral fat. And so in lower waist hip ratios than women who were not. So you're more likely, or you're less likely to see that kind of sloping up of visceral fat than you do if you're on hormone replacement therapy. And so that with less visceral fat, you have lower risk of heart disease, cardiovascular disease, stroke. And so
glycemic control and less risk of diabetes as well, right? So that kind of wraps up all into the whole glycemic control as well. Yeah.
Right. So we're seeing, increasing insulin resistance with no changes in diet and exercise, as well as the lipids, like we talked about earlier, insulin resistance and blood sugars are going up in menopause as well. And hormone therapy seems to be able to blunt that effect, but you still have to do the work nutritionally.
Yes. And so if someone's listening to this and they're like, okay, well, besides, obviously getting the book and reading it and reading the plan more, what are some like super quick things? If they're really motivated today, they're like, I want to start making changes right away. So
not to trigger an eating disorder, but as an experiment, I recommend downloading a free nutrition tracker. My favorite is Chronometer, and there's a free version available. Most of the trackers have paid and free versions. MyFitnessPal or there's a million of them out there. So my favorite is Chronometer. And so download it and just eat what you normally eat. If you think you're eating healthy, eat what you normally eat for a week. Then go in that app and look at the nutrition and see if you are look at fiber, look at magnesium, look at omega-3s, and see if you're hitting the recommended amounts of your nutrition components. And you might be shocked how you are really lagging in a couple of key micronutrients. And then the next week, see if you can use food to increase that up. So when we're talking about visceral fat specifically, women who have 25 grams of fiber in their diet per day or more have less visceral fat. Women who have less than 25 grams of added sugars in their diet per day have less visceral fat. Women who have something in their diet, either a supplement or a food source rich in probiotics every day, have a healthier gut microbiome and have less visceral fat. Women who have turmeric supplementation have been shown to have less visceral fat, and women who move their bodies on a regular basis with cardiovascular, usually in zone 2, have less visceral fat every day. So these are the things I counsel my patients about.
So what are your favorite, like in your book, I know you've got lots of recipes, lots of little tips and tricks. So, I mentioned in the beginning, I'm doing intermittent fasting and I've got my black coffee in the morning with, you told us on your social channels, cinnamon and salt, and it really makes the coffee much better.
Yeah.
So that's like one little trick I learned from you. But
black coffee is part of my fasting protocol. And in order, some people just don't like the taste. It's really bitter. And if you add just a little pinch of sea salt to the grinds and a sprinkle of cinnamon in the grinds. So I have a Keurig that I have the little cup that I just put fresh coffee in, and I don't use the pods because waste and cost. And so I'll put just a little pink of salt and then a sprinkle of cinnamon, close it up, and then brew the coffee. It will cut the bitterness, and it's so delicious. The salt seems weird, but trust me on this one. And Dr. Menn does it as well, it sounds like. So that's one little trick. One of my followers' favorites is, if you can tolerate dairy, is what we call the Mary Claire Parfait. And so it's plain Greek yogurt, full fat, plain Greek yogurt, half a cup or so. You're going to have sliced berries or just some fresh berries on top, maybe a quarter cup of that, quarter cup of nuts of your choice. And then I add ground flaxseed, chia seeds, and hemp seeds for the extra proteins and omegas and healthy fats. And it's a great way to break your fast, and you get that punch of, tart and sweetness naturally from the fruit. The Greek yogurt has lots of added proteins. So you're getting your protein goals, your healthy fat goals, you're getting fiber, you're getting micronutrients. It's just a beautiful, easy way. And you can mix up the nuts and the fruit day to day. So you can have different ways to hit your micronutrient profile.
So, and this is a good reminder that the focus is on counting the nutrients and not
the calories. Yeah. So it's a great way to kind of and I get it. It is a mental hurdle for us to let go of calories because we just did it for our whole lives. But really, it's miraculous when you let go and focus on getting good nutrition, that for most of us, if we can get the right amount of nutrients and fats, your hunger and satiety hormones will kick in the right way and naturally curb your appetite. So you don't eat more calories than you need. It's how we were developed as human beings. And we were genetically programmed not to overeat. And so the way that modern industrialization of the food sources, it's just overriding those systems and causing us to go try to get more food.
Yes. So before we were going to jump into the questions, because I'm sure we have a ton of them, but so I'll just say what, recently has inspired me to change, my personal routine is one, I am doing intermittent fasting and focusing on your principles. And I'm always preaching that we have to, do resistance training. So that's something new that I've committed to twice a week on my calendar, on my schedule. And with the consultation with my own doctor's oncologist, I am taking low dose hormone therapy. And I just bring that up because I think it's important that, women understand they should always be given access to shared decision-making, access to information, and to make that personal decision with a qualified physician. So that's what I'm doing. So if you don't mind, will you share what's something about your personal routine or, how you handle your menopause personally?
So I'm also on hormone replacement therapy. I utilize estrogen and I have a uterus still. So I do take oral micronized progesterone. I found that my sleep's a little bit better. And I take my progesterone at night. My practitioner and I have chosen estradiol because it is most similar to what my ovaries used to make. And I am taking oral micronized progesterone because progesterone is what my ovaries used to make. And I've done really, really well with that. I have added in a little bit of testosterone. I do use a compounded testosterone from a local pharmacy here. I'm using it off label because I genetically have low muscle mass and I am trying to hang on to that. And I am doing resistance training at least three times a week. As well as cardio, probably 5 to 6 days a week, 30 minutes or so. And so to try to help me now that is off label, that is something that don't have a lot of studies in women in menopause, but data is looking like it probably would be a little bit helpful and not harmful. The only time I prescribe testosterone is off-label is for that indication. On-label is for hypoactive sexual desire disorder in the absence of other causes of low sexual function. And so I do not routinely, I see a question there, so I'm answering it now. I do not routinely prescribe testosterone for everyone. I just don't have enough data to support that. So I did my exercise, my nutrition. I don't track every day anymore. Every day, certainly I did in the beginning and when I was learning, kind of rethink nutrition and my eating plan, but I don't feel like I have to track it every day anymore because I've kind of got the system down. If I ever find myself kind of going off plan too many times, I'll start tracking to get myself back, when I'm letting life get in the way and falling on convenience foods, which life happens. I've been traveling so much talking about menopause lately. And so I am tracking this week to kind of try to help me get back on track.
Yeah. And what you said about testosterone is really interesting. And this is an example of personal choice, shared decision-making, and using the best evidence, to deal with your own personal situation. And Alloy in my own private practice, I agree. We try to optimize, obviously, your nutrition, your health, hormone therapy with standard FDA approved products. And then if you're, doing all of that and you still have hypoactive sexual desire disorder, there are very, very clear guidelines. We don't need to be scared of testosterone. There's clear guidelines. And those guidelines do not include putting pellets in at the first start of menopause. Yeah. So this just kind of loops back to that. Yeah. But yeah, this was great. So let's open it up to the chat. So here we both can see them. And so I'm going to remind everybody, if you're enjoying this and you want to learn more, Galveston Diet is offering 20% off the purchase of the program or the program plus. Alloy 20 is Galveston Diet's code. And at Alloy, it's $25 off your first order. The promo code is collab25, and we'll put that up again at the end. So let's just, all right, well, we answered the testosterone. Estrogen dominance. Can you please talk about estrogen dominance?
So estrogen dominance, I think, was a innocent way to describe what happens in oligoovulation, which is what happens in perimenopause. But somehow the non-evidence-based medical world has gotten a hold of it and turned it into this fake medical diagnosis. I would never pick up the phone with Dr. Menn and talk to her about a patient with estrogen dominance. That is not a medical term. It has become a marketing term. So what happens in perimenopause and what happens in polycystic ovarian syndrome, so perimenopause and PCOS look a lot alike on multiple forms, and I have a blog about this on my website. You begin to not ovulate regularly, okay? And what happens is that we have kind of a baseline production of estrogen, and then it starts peaking around ovulation. And then we have ovulation, your progesterone surges, your estrogen drops off, then the progesterone drops off. That's a normal menstrual cycle. So in perimenopause and in PCOS, or any time for whatever reason, times of starvation, you are not ovulating regularly, that continuous estrogen production continues. And then you don't have that sloughing off each month with the surge of progesterone. Somehow people are being talked into that they have this estrogen dominance. Simply, they're just oligoovulatory, meaning they're not ovulating regularly like they used to or never did because of an endocrine issue. And
you just froze for a second. I hope it's just me seeing you freeze, but
you there? Am I there?
You're back. You just froze for a quick little second.
Okay.
So
if you're oligoovulatory, if you're menopausal,
I think what you're saying is that the estrogen, there's a lot of estrogen production, but if you're not ovulating, you're not making progesterone.
You're not making progesterone.
So you have a lot of symptoms.
Now I froze. Are we back?
Dr. Mary Claire, are you back?
I'm back. Can you hear me?
Hi, Dr. Menn here. I think we're back. I'm here. I don't see Dr. Claire here. I'm going to keep on asking these questions as we get Dr. Claire back on. Dr. Claire, are you there? Mary Claire, I'm sorry, I'm calling you Dr. Claire. Dr. Haver. All right, so I think we're breaking the internet. So we've got over 1.2 thousand participants right now live. So I think maybe we're loading the system. So quickly, how do you know you're in menopause if you've had a partial hysterectomy? This is a common question. Go for it.
So one of the easiest ways to tell, certainly if you're having symptoms, if you're having hot flashes, night sweats, brain fog, mood swing, all the things, okay, I don't need to do a lot of blood work to prove that, or you're over the age of 55, If, however, it's questionable, there's an easy blood test to tell us if you are fully postmenopausal, not perimenopausal. Remember, that's a clinical diagnosis. We don't have a great blood, urine, or saliva test for that. And so, but how do we know for sure if you're postmenopausal? And all that's going to do for us is really change the dosages of what we're going to give you to treat your perimenopause. Perimenopause treatment is very similar to full menopause treatment, but we tend to go with higher doses because we need to suppress the occasional ovulations.
Yes. So I'm age 62. Is it too late to start hormone therapy?
Great question. So, the best time to start hormone replacement therapy, as far as the long-term health benefits, as far as like cholesterol and diabetes and heart disease risk and neurodegenerative risk, seems to be within the first 10 years of menopause. So at 62, if you say went through menopause at the average age of 51, we are probably going to lose some of those long-term benefits, but absolutely it will keep your general urinary system healthy. It will keep your bones protected. It's going to help your hot flashes and some of the basic symptoms, but we might lose the edge on some of the long-term health benefits. So it is not too young to start. We just have to kind of lower our expectations there.
Yeah. And if you're doing well, there is no arbitrary time limit or cutoff. That's one of the reasons why HIMSS updated their guidelines last April. And someone asked, will the recording be sent? It's going to be on our YouTube, so don't worry about that. Late onset menopause and fibroids, is estrogen an option or will it feed the fibroids? Common question I get. It's safe to take, but let's hear it from Dr. Haber.
So, for both endometriosis history and a history of fibroids, there has never been a FDA approved level of therapy that has shown to make fibroids worse, bring them back, keep them from, degenerating through the menopause process, or reactivate your endometriosis. Yeah. We have a whole generation of women in perimenopause and menopause who are being categorically denied hormone replacement therapy for no reason because of a history of fibroids or endometriosis, and you absolutely can take it.
Absolutely. And I know there are studies, and in my practice, if someone had very higher stage or extensive endometriosis, and they've had a uterus removed, had a hysterectomy, sometimes I will add in a little progesterone just to help. So that can be something to be done. I love this one. I heard about symptoms of itchy, dry ears and frozen shoulder on TikTok. But when I mentioned it to my OB-GYN, she looked at me like I had 3 heads. Is it valid? Well, it's not valid for the doctor to look at you like you had 3 heads.
Right. She doesn't know what she doesn't know. And I did not know. It was me being on TikTok and enough people asking me that I'm like, God, that's a lot of people. Let me look this up. And the orthopedic data absolutely supports that there is an increased incidence of frozen shoulder having to do with perimenopause, directly related to hormone levels. Estrogen is an anti-inflammatory hormone. Capsulitis is an inflammatory, and capsulitis, which is what happens in the shoulder, is an inflammatory process. And so you take one away, the other one goes up. Easy enough. Dry, itchy skin, itchy ears, skin changes. Absolutely. We decrease our oil production in the skin for most of us through perimenopause and menopause, and that will lead to dryness and irritation. We also see an inflammation of nerves. And so nerves in the skin can become inflamed as well. And so we usually treat the skin issues with topical, hormone replacement therapy can go a long way actually, but we have emollients we can put on Q-tips. Most ENTs will tell you not to put Q-tips in the ear, but that's an easy way to get the medication where you need it. For some, even topical steroids can be helpful.
I've seen an ad for FDA approved drug Addy. What's your thoughts? Does it work? It's supposed to be female Viagra. I'm just going to say the most important female Viagra, and I learned this term from Dr. Rachel Rubin, is like vaginal estrogen. I mean, exactly your female Viagra, but if you need to improve the tissue quality with topical safe vaginal estrogen and systemic hormone therapy, if you're feeling horrible night sweats and hot flashes, you're not going to want to have sex. So maybe treat your menopausal symptoms, but kind of your thoughts on sexual,
So Addy and Vyleesi are 2 similar medications, and where testosterone is a hormone that it, can work on different levels in the brain and increase desire. Addy and Vyleesi also work in the brain, but more at the level of the neuroreceptor. So, and so similar to the way an anti-anxiety medication or an SSRI or SSNI work, Addy and Vyleesi work in that class. And so they were only studied in premenopausal women, so which includes perimenopause, but so women not in menopause, they were studying younger patients, and the results were modest, but they were there, that they saw an increase in their desire. I don't like the term libido. I think it's misused. I think it's used as a way to shame women and crutches. And so the medical term is hypoactive sexual desire disorder. It was a modest but improved increase in the frequency at which they felt receptive to have a wanting intercourse. And women seem to be happy with that. The problem with those two is they can be really expensive. There's not generic options available yet. And so when I lay out my options for my patients, most of them choose testosterone because of the cost. And then I do have patients on it, yes, of course, who have not done well with testosterone, or they just wanted to try it. So
which is fine. It's just another tool.
Mm-hmm.
Yeah. For me, it's generally not the first tool I go to, but it's certainly one of the tools.
Mm-hmm.
Someone said, I finished your book. I did the plan and lost 10 pounds.
Hey!
Or what meals to follow. Lastly, I'm a runner and unsure to know what food to eat before I run, if not time.
So ease into fasting, especially if you're a morning runner. And when when you're running, if you don't want to, what we call bonk in running, I used to I've totally changed my exercise in menopause for multiple reasons, but I used to be a marathoner and not anymore. So it depends on how far you're going when you're going to hit your bonk. And so when you're basically going to run out of your stored glycogen. And so when I first, counsel patients, the night before, you need to make sure you're getting your carbs in, you're getting your fiber in, you're going to restock your liver. So you have fuel to feed you through the workout. But at some point, we're going to run out of fuel. And so using GUs and the long chain carbohydrates can be helpful. Eating sometimes a banana or something that's going to give you, fiber, but enough glucose so that, fructose that can be easily converted so that you can have that energy where you need it. Our bodies need carbohydrates for fuel. We cannot demonize all carbohydrates. And so, but it is trial and error because we're all different. We all have different protein loads. We all have different, muscle mass needs, body fat. And so I can't make a general recommendation. You kind of have to experiment a little bit.
So some simple questions that are really important. What test should I be getting from my doctor when having symptoms of menopause?
A TSH. I have a blog about this of tests that might be helpful and what symptoms you need to make sure you mention so that insurance may cover them. Doctors they don't have magic wands or they don't have crystal balls. You have to be really clear about what your symptoms are. So when a patient comes to me for, her menopause care and she has a list of symptoms, I need to make sure 9 times out of 10, I'm not checking hormone levels. Okay. I'm making sure that this is not, I have to untangle. Is this really a thyroid issue? Is this contributing? Is she having autoimmune disease, especially if she's coming in with multiple, joint pain, morning stiffness? Do I need to make sure she doesn't have lupus? Does she have a vitamin deficiency? What is her vitamin D level? So I have a list of all of these tests on our website and our blogs about tests that can help you get the most out of your annual checkup if you're having these symptoms. So, and it's not one size fits all. You should not have cookie cutter labs you're doing for everyone. Of course, a lipid panel, that is cookie cutter. I always check a CBC, complete blood count. But there's other disease states that can look a lot like perimenopause and menopause, and we want to make sure we're not missing something.
Yeah. And I always think women at midlife should know, there's some basic numbers you should know. You should know what your fasting glucose is. You should know what your hemoglobin A1C is. You should know your lipid panel.
Yeah.
Periodically, know your vitamin D and a TSH. These are like basic things. Here, what is a great over-the-counter estrogen I can try? There are no safe or well-studied or over-the-counter estrogens, right, Dr. Haver?
Run. Do not take an over-the-counter estrogen or progesterone.
Yes, let's see. This is a good one. I hated the side effects of hormonal contraception, but I also have the same problem with HRT. And I think this is really important for people to understand. The formulations are quite different, actually, and it doesn't mean that you're not going to be able to tolerate HRT. Do you want to?
Right. The majority of birth control pills are much higher dose, unless you're on compound, than the way some people compound, than what you're going to get in traditional menopause therapy. It's like a percentage of the dose. And most birth control pills contain ethinyl estradiol, and there are about 9 different progestins that are in the birth control pills versus a hormone replacement therapy that usually is estradiol. There are some synthetic out there, and I'm not knocking them. What I don't prescribe very often is conjugated equine estrogens. Not that I don't think that they're medically efficacious and they work well. I don't like ethically what they do to the horses to get the urine as a horse owner.
We have we have so many other good
there's so many great options that I don't feel like this is necessary for me to prescribe. Though it was one of the first one, and there are studies. That's where the WHI data came from. So I just tend to not prescribe those.
Yeah, I agree. I'm just going to answer this quickly. Breast cancer survivor, estrogen, fed 10 years out. Can I take HRT? So I'm just going to say super important that this is obviously, we're not giving medical information, your medical advice to any one individual case, but this is a process of shared decision-making, something that, you can speak to your oncologist or someone who's menopause literate, who understands that there are studies and nothing is black and white. And it may be in certain, breast cancer survivors, that may be an option. So jumping to a family history of high risk for breast cancer. Am I not a candidate for HRT?
That's a family history of breast cancer is not a contraindication for hormone therapy. A history of a gene that is putting you at higher risk for breast cancer. You may choose not to take it, but it is not an absolute contraindication. At this point, it is, and even a personal history of breast cancer, depending on the type and your risk tolerance, is, you may still, as is Dr. Menn, be a candidate for hormone therapy in your menopause. It is a balance of your risk tolerance to potential health benefits, and you get to make that decision. It's shared decision making as to your own risk tolerance and what your potential benefits are. Your number one cause of death in women in menopause is heart disease. And hormone therapy is more effective at preventing cardiovascular death than a statin in women in menopause. These are the things you need to understand.
Yes. And I think to reassure everybody, NAMS has a formal clinical pearl on this, that women who carry a BRCA1 and 2 gene or have a very high risk based on family history should never be denied access to menopausal hormone therapy to treat their symptoms. This is interesting. Benefits of HRT extended past the age of 65. This woman says, I'm afraid it will be taken away from me when I hit 65 or 70.
You should not be denied access, especially if you've been on it for a while and you've done really well and you've not developed any contraindications along the way.
Is bleeding while on combined HRT normal?
Yes. So remember,
right? Yeah.
We're waking up tissue that has been sleeping for a while. And so it is, very normal and expected. I always counsel my patients, don't flip out if you start bleeding. It's not a period. Doesn't mean it's not working. Nothing's wrong with you. It's usually self-limited. It is annoying. I get it. But it is, make sure you tell your doctor and that she knows. But rarely is it a sign that something pathologic is going on.
This is a good question. Will you please explain why we do not need to check and monitor hormone levels? And I think let's take this question for like the true menopausal woman, so not perimenopause.
Right.
So, because people ask me this all the time, and they're confused, doctor, why shouldn't I test my level?
So there's not a therapeutic range. It's not like when we give thyroid hormone, where we know that, your TSH should be a certain level, your T4 or T3 should be certain levels. We don't have an established therapeutic range for estrogen levels in menopause. That has never been established. And anyone who's trying to tell you that is not well educated or trying to sell you something. And so we treat symptoms. So say my level is 100 and Dr. Menn's level is 100. Okay. 100 millipicograms per whatever, is in the reproductive range. Well, I'm hot flashing for Jesus, and she feels great. Are you going to deny me more hormones because I'm therapeutic? No. And so we treat based on symptoms and how you feel and how you're doing, rather than some arbitrary blood level test, the expensive blood test that needs to be done.
Yeah. And also I like to point out, when we do a blood test, that's not what's actually hormonally active in the tissue at the level of the tissue receptors. There's no way for us to test it. And just like some women have really bad PMS, postpartum depression, breast tenderness during their periods, all of our receptors act differently to hormones, and there's no blood test to test that, so that's important. And I see we're at the hour mark. So I'm going to ask this one last question because I think this summarizes a lot of things. My OB-GYN will not give HRT. She doesn't believe it. She instead prescribed Paxil. I feel like she ignored my conversation about HRT. What's the best advice that we can tell this woman, Dr. Haver?
Find a new provider. If you are categorically denied the conversation, not every woman's going to choose it or be a candidate, but every woman deserves the conversation and the option. And anyone who's going to categorically deny you access to hormone therapy, don't go call ahead, ask, or try one of like Alloy, try. If you can't find anyone you can see in person, then try one of the online, options, because you deserve the conversation. You deserve to understand what your risks and benefits are. And this provider is not educated herself, has not kept up with the latest data. And quite frankly, it's just easier not to give it. You are busy, you're doing surgery, you're delivering babies. Who wants to deal with hormone therapy? You're menopausal, get over it. It's time of your life. That has to end. That has to end. We're doing a tremendous disservice to patients, as a profession, and she's not alone. There are multiple providers out there who just don't want to give it, don't feel like it's worth their time and energy, haven't educated themselves. It's not Santa Claus. This is not a belief system. This is a medication that's been clinically proven to prolong your life and your health span. And so.
Yes. Well, excellent. That's exactly what I would say. Kristen, do we want to just put up the slide one last time so people can see the codes? And we're going to say our goodbyes, and there will be, so give us a day or so, and it's going to be, we're going to have the recording up, and we're going to take note of the questions that we did not answer. And if you follow Dr. Haver, follow Alloy, follow me on our social handles, we are always, all these questions come up time and time again. So if we didn't get to yours, we've probably answered them in the past, and we will continue to have these topics answered on our social channels as well. So, and check out Dr. Haver's book and come to Alloy if you're not getting access to care. And this was amazing, Dr. Haver. Thank you for all you do and for all the information you provide. You're inspiring.
Thanks for having me. This was so much fun.